Dr. Shalini's talk, missed Dr. Shada ma'am's talk, but Shalini spoke, covered it very well. So now we will be taking questions in the end, and a very brief talk right now on different innovations and breakthrough in IVF. So first of all, I would like to say most of the things are still not very time tested. We don't have much data about many things, but things like, you know, pre-implantation genetic testing and time lapse. So we have ample research and data to say where do we stand regarding these innovations and breakthroughs in IVF at present. So various things which are there are genetic screening, time lapse, stem cell therapy, assisted hatching. I will not say a latest technology because it's there since 1990. And the latest addition is artificial intelligence, which I will be covering in brief. We'll talk about it. So first of all, coming to pre-implantation genetic testing, which is something I believe that we have ample literature to say whether it is supported, it is not supported. So let's take that first. So PGD, as it stands for pre-implantation genetic diagnosis, it mainly demonstrates the abnormal cells, and indications of PGT are advanced maternal age, recurrent pregnancy. So right now I'm taking these indications as in general. Then we will come to the classification also. So advanced maternal age, then recurrent pregnancy losses, repeated implantation failure. In male factor, sometimes when we are not getting good blastocyst and it may be because of genetic problems, then it has got a stand. Then PGT in good prognosis patient undergoing single embryo transfer, as in US, they are doing it for all the patient, and they are putting in only single euploid blastocyst that can be done when patient is going for single embryo only. Then PGTA in donor egg, which we usually don't practice in our country. And then for most importantly for monogenic disease, when we already know that we are doing this procedure specifically for diagnosing any mutation, any specific mutation, I should say, on the embryos. So as far as classification of PGT is concerned, in as per ACOG 2020, we can classify it as PGT-M, where it is only for single gene disorders. Then PGT-SR, which is for structural rearrangements, and PGT-A. So PGT-A is generally when we are testing for any aneuploidies. So this is the latest classification as far as PGT is concerned. Now the question whether the new ART bill, ART law allows us for PGT or not. So if you read this in white here, so, you know, this portal regarding ART 2021 law, it has defined each and every terminology and has given the definition for each and everything. So earlier there was a little kind of concern whether this new law is allowing PGT at all or not. But clearly they have mentioned the definition beautifully here if you go on this portal online. And they say that PGT, which is mentioned in the law, is defined as analyzing the DNA from oocyte or polar bodies or embryos at the cleavage stage or blastocyst, which can be either for HLA typing for determining the genetic abnormalities. And this includes PGT-A and also includes PGT for monogenic or single gene defects and PGT for structural rearrangement. So that classification which ACOG has given, our ART law, which we were actually a little doubtful when the law came in a beginning, because this was a modification which was done later probably, because earlier this definition was not clearly visible online also, but later on when we searched and we really went in depth whether this is allowed or not as per new law, it is allowed in indicated cases. Now the most common PGT done is PGT-M, where there is a monogenic disease, which is the cause of concern, you know, sickle cell anemia running in family, both the partner sickle cell carrier or spinal muscular atrophy, Fragile X, condition like muscular dystrophy, cystic fibrosis. So they all come under PGT-M. As we know in India, you know, we have five common genetic disorders like beta thalassemia, cystic fibrosis, sickle cell, spinal muscular atrophy, and hemophilia A. So that's why we keep getting patients with one condition or the other, not so commonly, but yes, you know, if you really investigate your patients well, you will find some thalassemia carriers. And when you go on testing the other partner, then sometimes other partner may also turn out to be thalassemia carrier. So there is a role of PGT-M in such cases. Similarly, in African countries, there are so many cases of sickle cell we are getting from, and most of the times, you know, both the partners may be sickle cell carriers. So I'm just giving you some examples. Similarly, spinal muscular atrophy diagnosis of this condition is sometimes retrospectively made when something happens to a newborn child, and then, you know, parents are tested. And this is how I also identified one of my couple who came to me with history of sudden neonatal death, and then we did expanded carrier screening, and both the partners were positive for spinal muscular atrophy. So what exactly is done? So we are not, today I'm not going to go into the details of each and everything, but just to touch on, because pre-implantation genetic testing is the most important one, I feel. So I have put some slides for this in detail. So how exactly pre-implantation genetic testing is done is complete genetic workup of the couple and family, then genetic analysis, which is called pre-PGT testing, that is done. Then the mutation, which is responsible for a particular thing, particular disease, that is identified, followed by IVF, and then you know, taking the embryo to the blastocyst stage and doing trophoectoderm biopsy, and separately kind of diagnosing which embryo is disease-free and which embryo is carrying the major disease, and using only the normal embryos. So when we, you know, look at specifically at PGT-M or some genetic disease, it should be clear that we have to know the, you know, how that particular genetic disease is inherited. It is very, very important. So that's why we always have to keep a genetist in loop, and it is to be kind of, you know, multi-speciality approach rather than an IVF specialist or a clinician only handling or tackling the case. A genetist should always be involved, and nobody can remember all this by heart. So you always have to refer back to the books. Patient coming with one particular syndrome or disease, how it is inherited, how much is the chance that disease will get transmitted to the child, is PGT indicated or not indicated. So we also should know this, that it's not that as a rule all such cases have to go for pre-implantation genetic testing, because we also have prenatal testing which can be done when the mother is pregnant. But if after counseling couple says that they don't want to take any chance, because suppose that you know, the developing child in uterus turns out to be a case of major disease, then there is no option then to abort the child. So some couples would want, no, they want pre-implantation genetic testing. So I personally feel that counseling is very important to reach at conclusions, and it has to be a mutual decision. Patient sits across the table, proper counseling is done, genetist is involved, and then we reach at conclusion that yes, we have to go ahead in particular case for PGT or not. Similarly, we have done some cases of chromosomal unbalanced translocation in male and female partners, where there was history of recurrent abortions and all. So karyotype was done, and there was a chromosomal error, and hence, you know, PGT-SR gave good results. So this is just to tell you how old this PGT technique in world, I should say, because in 1990, this was first reported by Elena Contagiani, who was studying for her PhD, and she did this for X-linked disease. This PGT-M was specifically done for X-linked disease for the first time in 1990. So various stages to biopsy can be polar body biopsy, can be cleavage stage biopsy, or can be trophoectoderm biopsy. But the time-tested one is trophoectoderm biopsy, and this is the one which we are going for. But theoretically, if you ask, then even polar body biopsy, which has recently come in India, we are not doing it. And the preferred one is trophoectoderm biopsy, which gives most specific and sensitive results. So if theoretically we want to know why we don't do cleavage stage biopsy or why it is not preferred, because blastomy or biopsy at cleavage stage, it significantly reduces the reproductive potential of embryo by approximately 40%. And what's the, you know, kind of fun of doing such a testing? That's why it is preferred that biopsy is to be done at trophoectoderm, from trophoectoderm at blastocyst stage, which is day 5 embryo. So after the biopsy is taken, then the genetic material, you know, proper form filling and everything is to be kept in mind, and then this biopsy material is sent to the genetic lab, and depending upon what mutation, what disease, what chromosomal error we are looking for, There are different kind of tests which literature says can be done, and we leave it to the genetic lab and genetists, because we already do a pre-PGTM and a decision is already done that what kind of a testing would be done on biopsy, and accordingly it is done. So this slide I have just put to re-emphasize that literature supports trophoectoderm biopsy or day 5 biopsy more than cleavage stage biopsy, and that is one which is followed all over. Similarly, it is also important to know, rarely, I'm sure some of us must be getting these kind of cases also, like a bacha in family is thalassemia major and they want a HLA matched another child. So even for that, we can think of doing PGTM with PGTA with HLA matching, and embryos with same HLA, can be used to make the lady again pregnant, and that child can be a savior for the already existing diseased child in family. So this is something which we should know, that even with pre-implantation genetic diagnosis, even this is possible. So what are the practical problems? It's not always green. So, poor responders, we sometimes don't get much eggs. Then sometimes we need more cycles to, pool embryos when we are sending them for genetic diagnosis. And sometimes some patients, if the egg quality is or sperm quality is too poor, then they don't form blastocyst. The entire this effort goes in waste. So these are some points which we have to keep in mind, and especially when we are counseling poor responders or girls at higher age towards PGT for some reason or the other. So these points are to be kept in mind. Then another very important thing is, even if we have done a pre-implantation genetic diagnosis or genetic testing for aneuploidies, it is very important that for PGTM, where we are looking for a specific mutation, when the lady conceives, we are supposed to do an additional testing, either CVS or amniocentesis, depending upon what disease it is. So we, this genetic lab, when they give the results, they always mention that 1% of the cases can be missed. So we have to counsel the patient that even if you have done a PGTM, even then, there may be a mistake, 1% error can be there. So it is advisable to go for CVS or amniocentesis. Most of the patients don't want to go because they are, terrorized by the mere idea that it can lead into abortion. But still, your paperwork should be complete, and we should all know that even if we have done pre-implantation genetic testing, this counseling has to go. This slide I put just to tell you that how the report comes from the lab. This was one thalassemia carrier couple, both thalassemia carrier, husband, wife, and all 4 blastocysts turned out to be normal carriers. So they are usable because the child is not going to have major disease. Similarly, this was another case of thalassemia where you can see the last column shows the report of the final report. So first embryo was thalassemia major, then normal, then major, then minor, normal. So minor and normals are usable. Of course, we will use the normal ones first, and then if it doesn't work, God forbid, then minor can also be used maybe for second pregnancy or second child. Now coming to the ACOG committee opinion as far as the pre-implantation genetic diagnosis or PGT is concerned. So ACOG says there is a revision of terminologies which we have already discussed. Then apart from monogenic disorder, this can also be used for hereditary breast and ovarian cancer. Again, very, very important. Suppose you have a family where breast cancer, BRCA1, BRCA2, these genes are positive, or some other genetic hereditary cancers are there, then even in those cases, the pre-implantation genetic testing, PGTM, can be used to look for the normal embryos. So we should have this idea that, IVF followed by PGT does play a role in such cases also. Then to find HLA compatible embryo, as we just spoke about, trophoectoderm biopsy is preferable, and chances of misdiagnosis and additional prenatal testing is recommended. This also we discussed just now. PGT-SR, as I said, it is structural rearrangement. So some translocations like Robertsonian translocation, they can be missed. So always and always supplement this with CVS and amniocentesis whenever we have such cases. Now coming to PGTA, do we universally do it? Because we know it is to check generally the aneuploidies. So ACOG committee opinion is there is insufficient evidence to recommend the routine use of pre-implantation genetic testing in all infertile females. In addition, ideal genetic platform to analyze all chromosome has not yet been established. Worldwide, RCTs are needed to identify which genetic cohort would benefit from aneuploidy screening. As of now, what are the indication for PGTA? If there is a higher age, there is a case of recurrent abortion, recurrent implantation failures, they can get benefited marginally. So again, just to revise, if there is a specific mutation running in the family, then it is PGTM. It is very well indicated if couple wants. Then PGTSR, that is again indicated if suppose it is leading to abortions again and again. But PGTA, where we are, testing the embryos for general aneuploidies, there are only specific indications which are mentioned in this last line, and we should stick to it. So especially after this law has come, we cannot, we should not be subjecting all the patients universally for PGTA. That's wrong. So then as pre-implantation genetic testing cannot identify all genetic abnormalities, counseling for prenatal diagnosis, again and again, they have emphasized and re-emphasized. And sometimes there are mosaic embryos, so we have to counsel the couple for that also. Mosaic means there are two cell lines, maybe from where the biopsy is taken, it's not indicative of, because the biopsy is taken from trophoectoderm. So sometimes it has got a different cell line as compared to inner cell mass. So inner cell mass is actually the part which gives rise to the baby finally, whereas trophoectoderm will form the placenta. So sometimes there are two different cell lines and there can be a discrepancy. So that also has to be explained. Now, this was, I think, the most important one, the pre-implantation genetic testing. Then apart from this, there are additional latest technologies like embryoscope, time-lapse. Then this ERICA, which is embryo ranking intelligent classification algorithm. Then oocyte evaluation, artificial intelligence has also come up, but it is still experimental. And then non-invasive chromosomal screening. So let's see what is time-lapse. Time-lapse is basically a specialized incubator where there is a continuous video monitoring of development of embryos, and depending upon whether it is a high-tech embryoscope or it is the embryoscope which initially came in beginning, every 8 to 30 minutes they keep taking picture of developing embryos. So time-lapse takes digital images of embryos at frequent intervals. It assesses the quality of embryos without physically removing them. Potential advantages: there is stable culture environment, there is the changes in gas composition, temperature and movement does not happen inside the embryoscope, and there is an additional information, continuous monitoring embryo development it is giving to us. So I'll just give you an example. I had a couple where embryoscope showed 3PN, 3 pronuclei, and as per literature, all these embryos are usually genetically abnormal. They are not supposed to be good embryos. So, but the 3PN embryo, finally, it gave us a very good looking and morphologically very good looking blastocyst. But, at the end of day, this was 3PN initially. So we explained it to the patient. So had it not been inside the embryoscope, we would not have known. So it is just an example, but I'll say that most of the times nature takes care of, not letting the girl become pregnant if it is genetically abnormal. This is what is happening most of the time. So these things, they do add little bit to your maybe results, and that too in a very, very few cases. So if we look at this evolution, this is, box type, bench type incubator, and this is finally the embryoscope which has got a monitor, a video recording of development of embryo, which is incorporated inside this. Now, what does this literature says about embryoscope or time lapse? So regarding day 2, day 3 good quality embryos, some studies they support that if you put your embryos in embryoscope, they may give you a shapely better result, but most of the studies actually are not supporting too much. So if you look at the Cochrane database, it says there were no data on ongoing pregnancy or cumulative clinical pregnancy rates or cumulative live birth. So this particular study, it compared, time lapse with conventional incubation. Then it compared TLS with those time lapse where there is a embryo selection software also. So there are two things. One is a video monitoring is happening for development. Another is which says that this is euploid, this is aneuploid. So compared that software also. So basically, again, as the evidence was of low or very low quality, authors said that our findings should be interpreted with caution. So again, some extra help you may get in cases of recurrent implantation failures, or if you really want to monitor somebody who has recurrent abortions. So these are the cases where it can give you minimalistic addition, but otherwise implantation rate can improve a little bit. P value is significant here. This is again a data from Singapore and India combined data. So ongoing pregnancy rate, live birth rate was also a shade better. P value is significant, but fertilization rate, blastocyst rate. So there are mixed opinion in literature. So we can say that this is an add-on which can be used in some specific cases, but it's not that if your IVF lab does not have time lapse, then you are not doing good. That's not true at all. So possible reasons why this time lapse is probably giving a better outcome as far as implantation and all is concerned. Probably it's the uninterrupted culture. We're not taking out the embryo even to check for fertilization. We are not taking it out on day 2, and directly you can keep it in a media, which can take care of the growth till day 5, till the blastocyst stage. So now coming to, does artificial intelligence have a role in AI clinic, in IVF clinic? So artificial intelligence removes probably the subjectivity, and objectively it ranks the gametes and embryos based on the quality. So rather than me depending upon my embryologist morphologically which one is looking better, maybe it gives you an objective ranking of the embryo. But most of the times in all the artificial intelligence technology which is available till now, there is around 70 to 75% concordance rate, or we can say accuracy is around 75%. It is not above 90 or not touching even 80-85%. So artificial intelligence we are using even for selecting good sperms, which all of us are doing, microfluidics and all those things. So AI for oocytes, there is something which is very, very latest, which is AI for oocytes, where they give prediction how much is the chance that one particular egg will become a blastocyst. Suppose you are going for egg freezing for a girl and she made maybe 6-7 eggs in one cycle. So this software technology even tells us by say around 70% accuracy how much is the chance that there will be a live birth later on, provided these eggs are given an ideal sperm for ICSI. So but this is UK based technology, and the inventors, they themselves say that it is done only on 20,000 eggs as per now. So we need more literature and data to say that yes, it really does work. Now, embryo ranking, once embryos are formed, then genetic scoring and viability scoring. This is how it looks like. So this is a blastocyst picture, and it gives different scorings for viability also and for euploidy also, genetic scoring also and viability score. It sometimes whether it is in red zone or green zone. So depending upon that, it may kind of assist you choosing which blastocyst you should be using if morphologically there is a confusion. But at the end of day, again, not much literature to support all this. Stem cell, I'm not doing much. I think Dr. Sharda Jain ma'am is doing a lot of cases on stem cells. She would be able to give some opinion on this. So I'm doing PRP, but I preferably, stem cells for endometrial lining I'm doing, but not for poor ovarian reserve. There I'm restricting myself to PRP only. Then assisted hatching, I will say, is not a new technique. Again, there are mixed, it's there since 1990s. There is again a mixed literature review and opinion that it may help, especially in cases where there is recurrent implantation failures and old age, and especially where there's thick zona and you feel that the embryo will fail to implant, there it may help. Then coming to non-invasive chromosomal screening, where spent culture media is used. This is something, the media in which blastocyst is growing, that spent culture media is used to analyze the DNA of the developing embryos. And just look at these figures. Since 2016, to 2019, these various studies, they said initially when it was used, probably the technology just came in, the concordance was only 3.5%, but now people claim it is touching 80-85%. So again, the drawback is we cannot test a single gene mutation in NICs. We can only do the aneuploidy testing. That's why it is also called as non-invasive PGTA and non-invasive chromosomal screening. We cannot test single gene mutation by this. ERA, Dr. Shalini already talked about. I'll say this is again a artificial intelligence only. But ERA, I feel in natural cycle, because there is a lot of variation between two cycles, it's always a good idea to do it in HRT cycles. It's always better. And microfluidics, of course, it is something where we can segregate better sperms, and especially in cases of where high DNA fragmentation index is there or severe odds is there, it can work. And similarly, magnetic sorted for sperm sorting, it again works for compromised semen samples. So just to summarize, IVF success rate. So this is summary of all three talks till now. IVF success rate have improved significantly over past decades. I think all of us will agree with this. It is multifactorial procedure, and that is reliant on proper timing and accuracy, age, ovarian reserve, sperm quality, embryo quality, endometrial receptivity, timing of embryo transfer. It influences the success rate of IVF cycle. Implantation window is a time when endometrium is functionally competent to receive the embryo. Any displacement in the window of implantation can be determined by ERA. AI in reproductive medicine is still not much supported except for pre-implantation genetic testing. Coming to progesterone, progesterone prepares the endometrium for implantation by bringing secretory transformation of endometrium. And oral dydrogesterone, I feel, is is a good option, because this micronized progesterone vaginally is fine, but intramuscular ones, patients do have a lot of complaint. And especially after these two trials, Lotus 1 and Lotus 2, dydrogesterone is something which has really come up well, and I'm using it in a lot of patients. The newer practices such as tailored ovarian stimulation protocol, mild stimulation, elective single embryo transfer, frozen embryo transfer, blastocyst culture, they've all increased the pregnancy rates. That's all for the talk, and I think we are open for discussion now. Thank you so much for patient listening.
That was a wonderful talk, Dr. Sunita. You covered all the newer innovations in a very systemic and organized and a very crisp talk.